Hello and welcome to Investigator Insights. I'm Dr. Jim Epstein. Today we're going to be focusing on emerging multikinase inhibitors in thyroid carcinomas. This is an area that has been very exciting in the past few years with tremendous advances in the understanding of the biology of thyroid carcinomas, especially the differentiated thyroid carcinomas, and the identification of new molecular targets with the emergence of a number of targeted agents directed at those abnormal genetic and molecular targets. So joining me today for this first segment in this three-part series on thyroid carcinoma is Dr. Marcia Brose from the Abramson Cancer Center at the University of Pennsylvania. Marcia, thanks so much for being here.
It's great to be here.
Well, good. I mean, this is an exciting time, and the idea with these Investigator Insights programs is to speak to an investigator about what's been going on in a particular field, and you have been very much involved in the clinical trials in thyroid carcinomas. So let's take a little bit of a background. Thyroid carcinomas seem to be increasing in incidence, and they seem to have fairly particular demographics as far as who seems to be most susceptible. So tell us a little bit about the population that seems to get thyroid carcinomas, and what explains this rising incidence?
Well, the vast majority of people who get differentiated thyroid cancer are actually women. So there's actually 3-to-1 ratio of women to men who actually get it. And many of these women are actually young, who are under 40, under 45, and many of them will actually do very, very well. So the vast majority of people who get thyroid cancer will be cured. So about 90-95% will have very, very long-term survival. What happens is that depending on how old a person is, they may or may not have a more aggressive form. So the people who are over 45 tend to do a little bit worse, or more likely to have problems with recurrences and maybe spread of the disease. So we do take a closer look at those patients, follow them a little bit more closely. The rising incidence actually has been mostly in smaller lesions that are probably being picked up more because people are going to doctors for other things. However, there is some data that suggests that it's more than just that. And that there is an increasing incidence, and no one's really quite sure what could be behind that. So it may be some of it is increased detection, but some of it also is a little bit of increasing incidence, actually, where the cancers may be occurring a little bit more. But the bad part about thyroid cancer, when you compare it to all of oncology, is that we, until just recently, had made no progress in the overall survival. And I'm not sure whether we might be finally at the verge of being able to make a dent and actually start turning around the number of deaths per year with these agents. We'll all have to wait and see. But at least for the first time in over 50 years, we actually have some hope. We have some new agents that really are seeming to have an effect.
Right. Does radiation exposure play any role in the development of thyroid carcinoma? I read that there's an explosion of thyroid carcinoma following the Chernobyl accident a number of years ago.
Sure. In Chernobyl, and actually a lot of those now I think have actually been diagnosed, and many of them have started to go through the system. Of course, now with the Japanese nuclear accident, there's a huge number of kids mostly who are being screened for thyroid cancer. So radiation exposure absolutely has an increased incidence of thyroid cancer. Hopefully, most of those will be small, they'll be caught early, and those mostly children who will get it the most will be caught early and cured. However, there is some also exposure of some of the people, mostly not our generation, but maybe our parents' generation, who may have had radiation as a young child for acne. Sometimes cancer survivors who've had lymphoma or breast cancer survivors, they've had exposure to their thyroid too, sometimes from radiation. That can also lead to an increased incidence of thyroid cancer.
Very good. So for most people who are discovered fairly early, they get thyroid surgery, either a subtotal or a total thyroidectomy. They get radioactive iodine ablation and then thyroid suppression. How many of those people later get into trouble with more advanced disease and become refractory to radioactive iodine?
Well, only about 10% of people will actually have metastatic disease, and half of those people will actually have it from the start. But only about 25 to 50% of the people won't respond to those therapies that you just named, namely that they'll have surgery, they'll have radioactive iodine therapy, and they'll have TSH suppression therapy. Most people do. However, 25 to 50% of those people eventually will lose the ability to take up radioactive iodine. And when that happens, they're also more likely to have trouble with progressing disease and need to have some additional therapy. Those patients also are more likely to become PET positive. So at the time when they lose their ability to take up iodine, they develop the ability to take up the FDG glucose that we have in PET scans. So there's an interesting sort of a yin-yang thing where once they lose the iodine, we can sometimes start to track it using the PET scan.
Very good. Well, when people become refractory to iodine, what is the standard of care in this country, or is there a standard of care?
Well, so that's an interesting question. So the last time anything was FDA approved was in 1974. Doxorubicin, a chemotherapy agent, was approved. And after that, everybody realized that using today's standards, it would not have been approved, because basically if we use CAT scans, which they didn't have back then, we would have seen that a very, very small number of people were actually responding. And those who did responded for a very short period of time. Given the toxicities, the field generally didn't use it. So even though it was the FDA-approved drug, we didn't use it. So since then, and also with the coming of data from the phase 2 trials, the NCCN as well as the ATA, which are the two sort of major bodies that really give suggestions or recommendations on the treatment, have suggested that participating in clinical trials is #1 priority, and if not, treating with one of the kinase inhibitors.
Very good. So what has been learned about the biology of thyroid carcinoma that suggests that these tyrosine kinase inhibitors and other targeted agents might have efficacy?
Well, as it turns out, if you look at all of the papillary and follicular, which is the major two classes of differentiated thyroid cancer, the vast majority are associated with molecular abnormalities in what is called signaling molecules. These are the targets of the kinase inhibitors that we talk about every day. So when you have 70% of differentiated thyroid cancer associated with known mutations, you know, it's just asking to be treated with a kinase inhibitor. These mutations cause overactivity mostly of a BRAF, MAP kinase, MEK pathway, or the AKT pathway. And because of those two pathways, they have been the focus of most of the therapies that have been going forward. When you add that also to the fact that these are very vascular tumors, a major target has also been just the blood vessels themselves. So that's not necessarily a molecular target, but more a pathologic target. We know they're very vascular, and so that they need blood flow. If we decrease the blood flow, we hope to have a benefit. And it turns out that the VEGF receptor inhibitors are one of the major focuses for that as well. So that's probably where a lot of our activity has been as well.
So are these cancers addicted to a specific molecular driver, such as we see BRAF, V600E in melanoma and BCR-ABL in chronic myeloid leukemia? Or are there multiple drivers?
Well, so I think that there are drivers, and how much they're actually addicted to them is going to have to be worked out. So if you study it in cell culture, you might find cells that are addicted. However, in people, unfortunately, we don't have quite that good sort of on-off relationship. However, like melanoma, BRAF mutations are actually very, very common, especially in papillary thyroid cancer. And so they are very, very good targets. The problem often with targeting them eventually is that sometimes the cells figure out a way around the block. So they definitely are good targets. And so we have both the vessels, and then we target the cells themselves. And I would say that the targeting of the cells themselves, those studies are still sort of providing their data, and so we're still seeing how much the direct targeting matters. Sometimes it's very hard to pull it apart, right? Because you're actually targeting the blood vessels and those cellular targets at the same time, and it's hard to know which one is having the most effect.
Well, you mentioned that CAT scans have been used to monitor progress, and that PET scans can show significant avidity. What about some of the older measures of measuring thyroglobulin, CEA levels, calcitonin for medullary?
Right.
What is the role of those things and the newer technologies in monitoring patients for response and progression?
Well, so that's really interesting, because if you take the CEA and the calcitonin, which is only in medullary thyroid cancer, and you take thyroglobulin levels, which are followed meticulously for people who've had thyroid cancer, before they ever get to the kinases, those are very, very good markers of whether there's residual disease. There really shouldn't be any of that in the body after the tumor is removed.
Sure.
So that those levels mean everything before the kinase inhibitors are started. However, once you actually start treating with a kinase inhibitor, now you might be messing with the relationship between the actual level of the tumor marker and the number of cells, such that it may no longer be reliable. Now, as part of these large phase 3s, we're going to try to get data on that, and hopefully we'll be able to figure out whether or not they are predictive or not once you are on kinase inhibitor therapy. But it's not completely clear, and it's also much more of a research question still at this point, what you do after the kinase inhibitors have been started. But as an oncologist, when we start to treat this, we have a little bit of a different approach. So the endocrinologists, who are really after eradicating all of the disease, can use radioactive iodine. And that's very, very good with what we call very small volume disease. The cells that we don't see, or we can only see if they take up radioactive iodine, otherwise we can't see them on a CAT scan. And because of that, they use those markers because they're very, very sensitive to detect if there might be residual disease and then treat it. However, once you're starting to talk about kinase inhibitors and any kind of chemotherapy, you're not going to be giving that toxicity for something that you can't even see, because you're really going to be giving toxicity for something that might still take several months to a couple of years, maybe longer, to actually evolve and cause a problem for the patient. So when you become an oncologist who's treating these tumors, you really want to focus more on what we would call measurable disease. So we use basically a few criteria to say somebody would be appropriate candidate. The first is that they no longer take up radioactive iodine, or they've exceeded their lifetime dose. And generally in this country, we don't give more than 600 millicuries. By then we really know that if they haven't responded, they're not going to. The second is that we want to make sure that they have measurable disease, because if somebody has a bunch of lesions that are only 1 or 2 millimeters, it's unlikely that that's going to cause a clinical problem for quite some time. And until we actually have a therapy that we think can cure those patients, there's no reason to give them the toxicity up front. Third, what we usually do is we wait for them to have lesions that are bigger, or they're symptomatic from them. It may be that they have so many little lesions that they're symptomatic, in which case we would start therapy. But all of these, as you can hear, are things that we actually would pick up on a CAT scan, as opposed to an iodine scan looking for minimal disease. So what we really do is we try to wait. Usually people have to have 1 or 2 or maybe multiple lesions that are a centimeter, sometimes 1 lesion, but it's much bigger. So we usually wait till there's some more measurable disease before we would do that. And the main reason for that is this is a slow-growing tumor for most people. So following them and also seeing that they're progressing is another criteria. So if they have a stable lesion that hasn't changed in 3 years, I'm not going to treat it until it starts behaving badly.
Very good. All right. Oh, great. This has been very interesting, Marcia. Thank you so much. So we will end this segment and then move on and talk about some of the emerging multikinase inhibitors for thyroid carcinoma in the next segment. So thanks so much. And thanks to you for watching this first segment of Investigator Insights, Emerging Multikinase Targeted Agents for Thyroid Carcinoma.